we said, this is part 2 of our 3-part series, and today we're going to be focusing on treatment. And so this sort of comes after Dr. Squires today on the gnostic aspects. So really the management of Parkinson's tends to be very individualized based on people's individual symptoms and how people are doing day to day. So just because you have a diagnosis of Parkinson's doesn't mean that you require treatment. We kind of wait to use treatment until someone is experiencing any difficulties in their day-to-day activities. Treatment is not just with medication, and we'll be getting into this more tomorrow. But there's treatment of some of the motor symptoms of Parkinson's, which you would have heard about yesterday. Treatment also of some of the non-motor symptoms, and then also physical therapy and exercise as forms of treatment. And actually, exercise as treatment is a huge topic. That's why we have a whole session dedicated to it tomorrow. But exercise is really the thing that helps slow down progression of Parkinson's. And so for me in particular, when I'm seeing someone and they're doing a great amount of exercise, and then they tell me that they're feeling a little bit too stiff and slow to continue with that exercise, I really think that can be a good time to start medication. And my job is to make sure people are on sort of the right medications that they can do the exercise, which is the true treatment, and more on that next week. So again, it's very individual. Limiting your ability to do exercise or daily tasks is generally when we think about starting medication. So our mainstay of medication in Parkinson's for motor symptoms is levodopa carbidopa, or the brand name that you may know is Sinemet. This medication has been around since the 1960s, and it continues to be the most effective and the best medication that we have. The levodopa is what's called a prodrug, and so it actually gets converted to dopamine in the brain. You can kind of almost think of it like a supplement. So if your brain is lacking in dopamine, we give a medication to help supplement the amount of dopamine in the brain that your brain is making. The carbidopa is actually there to limit side effects and to make sure more of the levodopa gets to the brain where it can have its beneficial effects. So without the carbidopa, a lot more of the levodopa would break down in the gut and create a lot more side effects, and we need much, much higher doses to actually get an effective dose in the brain. As mentioned, it's the most effective and the most potent medication that we have. And our current understanding of Parkinson's is that everyone will require treatment with levodopa at some point. And so some of the questions I get from patients, does levodopa slow down Parkinson's progression, or the opposite? Does levodopa, is it toxic? Does it speed up progression of Parkinson's? The answer to both of those is no. So there's been a lot of research. You can imagine this medication's been around since the 60s. So we know that it does not slow down Parkinson's. It helps manage symptoms. And it's really exercise that helps slow down progression. We also know that being on levodopa medication does not speed up the progression of Parkinson's either. So it's not toxic. It tends to be a really well-tolerated medication. There can be some side effects. These are most common when people first start medication. Commonly, those would include a little bit of stomach upset or nausea, sometimes low blood pressure. We can avoid this if we start the medication nice and slow and increase it slowly. Sometimes we'd use other strategies, other medications as well to help minimize side effects, to kind of get people over that initial hump. Usually once people are sort of on the dose of medication, it tends to be really, really well tolerated, and most people are able to stay on this medication and at doses that are helpful for their symptoms. So this is a common one, again, sort of both sides. I've heard I should take medication with food, or I've heard I should avoid taking food. And like the answers to most things, that's a bit variable person to person. So I often will tell people if they get some nausea when they first, a bit of stomach upset when they first start the medication, you can take the medication with a little bit of food to kind of settle your stomach. But the medication actually does not need food to work. In some people, about 20%, sort of several years into Parkinson's, about 20% of people find that the medication doesn't work as well as if they take it with a large amount of protein. So sometimes when we're first starting medication, it's sort of easier to remember to take it if it's 3 times a day with a meal. And then, that's often fine for most people. But if you're kind of feeling that the medication is not working as well or that kind of thing, then one of the things we might do is move it away from food. Like I said, though, that sort of interaction with protein doesn't happen to everyone, and certainly is not very common when we're first starting medication. So we call the symptoms that improve with medication levodopa responsive. So it's no surprise that a lot of the motor symptoms, such as stiffness and slowness, will improve with this medication. So that's often what I ask people to pay attention to when we're starting medication. Tremor can be a little bit variable in terms of how well it responds to medication. So for some people, it responds quite well. For other people, it may not respond all that well. We may need higher doses of medication, or we may need different strategies to settle down tremor if it's bothersome. Interestingly, there are also some non-motor symptoms that can respond to levodopa. So sometimes people get soreness or pain that they feel is better on medication. Sometimes other things like sweating or sort of this feeling of anxiety actually can respond to medication. And for some people, urgency to use the bathroom as well. So a common question, what if I don't feel any different on medication? You should be feeling different on medication. So if you're not, you should be talking to your doctor about that. It's sort of what impact we expect the medication to have might vary a little bit on the type of medication you're on, how you're taking the medication. So we talked about kind of, with food, away from food, that kind of thing. A really big reason that people might not feel medication working as well is if they're constipated. So we know constipation is a common problem in Parkinson's, and if people are constipated, the medication doesn't get absorbed as well. There can be other rarer causes too that your doctor might need to investigate if some of the more common causes are ruled out. So the medication with levodopa, you might hear about it kicking in or sort of starting to work, and then we describe sort of people having an on time or a time that the medication is working, and then we might describe the medication wearing off, and then people having quote unquote off time where they're feeling some more of those motor symptoms or non-motor symptoms, so stiffness or slowness, for example. So if you don't feel the medication kicking in or wearing off when you start it, does that mean it's not working? So a lot of times early in Parkinson's, people will tell me they feel better on the medication, but they certainly can't feel every tablet start to work. And that's actually very common. So if we think of the therapeutic window for medication, early in Parkinson's, this window is quite wide. So you sort of take a dose, it kicks in, it's working, it wears off, and you sort of stay within that therapeutic window. So for someone like this taking medication, you feel better overall, but you're not feeling each dose kick in and work. If you miss a dose or delay a dose, you might not feel any different. For these people, often if they were to stop medication completely, which obviously I don't recommend doing unless you're doing it with your doctor to help direct how quickly or slowly to do that. But if they stop medication completely, then usually after several days to a week or so, they would be feeling the symptoms that they were having before. So feeling worse overall at that point. Now, this is a really big one. Oftentimes I hear from people, they've done some reading online and they've heard the medication stops working at some point. And so they want to know if they should be saving medication for later. And this is a really big misconception in Parkinson's. So levodopa and other medications never stop working. So starting it now, starting it later. The medication doesn't have a fixed lifespan. It does not stop working after a certain number of years taking the medication. What does happen is the brain changes with Parkinson's. So if we think of early on in Parkinson's, that therapeutic window we mentioned is quite broad. It's quite wide. It's easy to take a medication and stay in that therapeutic window all of the day and the night. As Parkinson's changes over the years, as things progress, that therapeutic window narrows. And so it becomes a little bit more difficult to keep people in that good on time without having sort of dyskinesias or extra movements, which we'll talk about, or feeling off in between doses. So it's not that the medication stops working, it's that the brain that it's working on changes after years with Parkinson's. So this is sort of a good representation. Early in disease here, sort of the medication kicks in and wears off. We're within this blue therapeutic window here. As disease progresses, that therapeutic window narrows somewhat. And so you might take a medication, and at the peak of the dose, you might get some extra movements or dyskinesias. These are kind of writhing movements. And then you might go through that therapeutic window again and have some off time in between. So dyskinesias are rocking or writhing movements. A sort of more extreme example of these would be Michael J. Fox. An important consideration for the question, will I ever develop dyskinesias, is age. So people who are younger when they have onset of Parkinson's are more likely to develop dyskinesias. Once people get sort of into their late 60s, 70s, 80s, developing dyskinesias is much less likely. Also, although they look very uncomfortable, for most people who experience them, they're quite a bit milder than anything you can find on the internet or YouTube, because usually only extreme examples get put up there. And most people actually are not particularly bothered by them, and actually prefer to be have a little bit of extra movement or dyskinesia compared to being in the off state. Our current understanding is that dyskinesias correlate with that longer disease duration and possibly higher individual doses of levodopa rather than kind of your cumulative or total dose of levodopa. Again, this is not a reason to wait to start medication, because if we remember this, the brain is changing over time, and that's what's leading to these dyskinesias rather than the medication alone. For some people, that means that we need to change dosing over time. So if we think of sort of 3 times a day dosing, if that therapeutic window is narrowed, sometimes just increasing each dose of medication 3 times a day is not going to be very helpful. And so sometimes after some amount of time, I thought I lost a slide there, we may be sort of changing the way we're taking medication or taking it more often throughout the day. I'll just talk a little bit about sort of immediate release or controlled release levodopa. You may be on one or the other or a combination of both. Usually we find controlled release sort of not as effective to use during the day for people. It's a little bit less reliable in terms of kicking in and how quickly it starts to work. And it's only about 70% of the effective dose of the immediate release. So sometimes changing from controlled release to immediate release can have better impact during the day. Here we are. So if we take more frequent doses, then even if that therapeutic window is narrowed, it's easier to stay within the window. And then there's also sort of advanced therapies that can help you stay within that sort of feeling good therapeutic window throughout the day. So one of those would be deep brain stimulation. So this requires some brain surgery. So holes are made in the scalp and electrodes are placed deep within the brain in areas of the basal ganglia that are responsible for movement and involved in Parkinson's. And there's a sort of an electrical signal that gets sent to those, and you can stimulate different areas in different ways. This isn't something that we're using sort of very early in Parkinson's. So initially, people are started on medication. Certainly, if symptoms are quite mild, it's not worth the risk of brain surgery. We often use DBS, or deep brain stimulation, to smooth out motor fluctuations. So if people are sort of kicking in and having dyskinesias and then wearing off in between doses, we can smooth that out with DBS. Now, it's important to know that the effect of the surgery is equal to levodopa. So those symptoms and parts of Parkinson's that feel better with levodopa are the ones that get helped by surgery. So we're not doing surgery in people if they're not responding well to levodopa, and it's important to know that it doesn't help all the symptoms of Parkinson's. So things like difficulty with balance or falls, difficulty with swallowing or thinking or memory don't tend to be helped by the DBS, and they can actually be worsened by it. So it really is sort of helping with motor fluctuations is the most effective way to use DBS. A newer advanced therapies is Duodopa, or an intestinal gel. So you kind of see this inside-outside picture here. This involves a tube that goes in to the stomach there, or the intestine, and instead of having to rely on orally absorbing each dose of medication, this is able to provide a more constant infusion, and so can even out motor fluctuations again. I'm going to talk a little bit about some of the less commonly used medications for Parkinson's. So one of these would be the MAOI-B inhibitors. So you might hear medications called rasagiline, selegiline, sulfonamide. This doesn't supplement the dopamine in the brain. It actually is sort of preventing the breakdown. So this enzyme is one of the ways that dopamine gets broken down and therefore is no longer useful in the brain. And so this helps it stick around for a little bit longer. This is thought of as a less potent or a less strong medication compared to levodopa, and so if people are having symptoms getting in the way of their day-to-day life, this might not be effective alone, and it may be something that we're using with in conjunction with other medications such as levodopa. Another medication is dopamine agonist. So we said that the levodopa itself breaks down into dopamine. A dopamine agonist medication helps the dopamine that's there work a little bit better. So we do sometimes use these medications, and one of these comes in a patch form, which can sometimes be useful to help with motor fluctuations or to help overnight. But this does come with more side effects compared to the levodopa. That's why even though these ones are a bit newer, we still consider levodopa our mainstay of treatment. So the major side effects with these include impulse control disorders, as well as rarely sleep attacks. So impulse control disorders are trouble with things like eating, gambling, shopping, sex, all those things. So we certainly avoid these medications in people who have any history of those sorts of behaviors or addictions. And then sleep attacks is exactly what it sounds like. Rarely people can sort of all of a sudden fall asleep on these medications, which obviously is something we have to be wary of with driving or work with heavy machinery, etc. One of the other medications, so another enzyme inhibitor, entacapone would be the common one in Canada, apicapone's in Europe, but not yet in Canada. And again, this inhibits an enzyme that breaks down dopamine, so makes it stick around for longer. This one we only use if people are on levodopa, because otherwise it's not having much of an impact. Amantadine is a medication that we sometimes use to help minimize dyskinesias, or those extra movements. Like many of the medications medications other than levodopa, we have to be quite cautious with this. Some cognitive side effects and other things, so we're using it quite cautiously. So this would be a common question that comes up, and I know this was talked about by Dr. Squires yesterday. So in terms of natural treatment for Parkinson's, there is what's called mucuna pruriens, or mucuna, created from the velvet bean, and the plant is thought to be about 2% by weight of actual levodopa. And so there are extracts of the seeds that can be bought. The major problem with this one, it is levodopa, so it's the same as the manufactured medication, but some of the difficulty is that it's very hard to know exactly what you're getting. So because this is a supplement, not manufactured as a drug, there's a huge range of what it says on the bottle and what you're getting. So for example, if it says you're getting 100 milligrams, there was a study that looked at tons of different types of this extract and found that it contains 6% up to 141% of what it said it contained. And actually none of the capsules contained kind of the 90 to 110%, so 90 to 110 milligrams if we're talking about 100 milligrams, which is what is required for a medication that you're buying that's gone through Health Canada approval. This also doesn't come with carbidopa, so when we talk about the benefits of carbidopa in minimizing side effects and maximizing the amount of drug that actually gets to the brain, it doesn't come with that. Moving gears a little bit to talk about non-motor symptoms. I know you've heard yesterday that non-motor symptoms are very, very common in Parkinson's. Some of these might be levodopa responsive, but some of them aren't. And so if people are on medication for other motor symptoms, they may still find that they have other symptoms that are not really being managed just by managing dopamine levels. One of those, for example, might be sleep. So people might have difficulty falling asleep or have sleep disturbances that aren't responding to levodopa. There can sometimes be sort of end of dose or off period anxiety, but sometimes people are having anxiety that's new when they're also having Parkinson's. We know there's a higher risk, and that often might need to be treated separately. Your family doctor is really key in helping manage and treat these symptoms. Part of the reason for that is if we're starting medications for anxiety, and that it is something that often needs more check-ins with a physician than you might be able to do with your neurologist. And so oftentimes what we might do in an appointment with a neurologist is sort of identify that these can relate to Parkinson's, sort of pick out some medications that tend to be effective in managing these symptoms in Parkinson's, and then are making recommendations to your family doctor that can help implement some of these treatments. You probably saw this yesterday, but there are a lot of symptoms that are sort of less obvious with Parkinson's. So, someone else might be able to see some of those motor symptoms, the tremor, or the change in walking, change in voice, or facial expression. But a lot of these symptoms of Parkinson's might go unrecognized if we're not specifically looking for them and talking about them. So changes in mood and anxiety are very, very common. And you probably heard yesterday, but it's not just that people are anxious or depressed because they have Parkinson's, but actually the mood chemicals are downstream of the dopamine chemicals. And so because one is impacted in Parkinson's, the other is very frequently impacted as well. This can respond quite well to different forms of treatment. So some of those are talk therapy, cognitive behavioral therapy, mindfulness. But oftentimes we might need to use a medication to supplement as well, to help kind of reset some of those brain chemicals. And so some of those we use are selective serotonin reuptake inhibitors, which is a big class of medication used for mood and anxiety. And then also sometimes mirtazapine, which can help with sleep and sometimes tremor, as well as anxiety. So if we think about sleep disturbances, this comes in a couple different forms. So people can have REM sleep behavior disorder or acting out of dreams. That can actually it's interesting. This is a symptom that sometimes the person experiencing it isn't all that bothered by, but sometimes we decide to treat it both to prevent injuries, but also to allow your partner to have a better night's sleep. And so this, one easy way to treat this is sometimes with melatonin, or there are prescription medications we use as well if melatonin is not effective. Insomnia can be quite common in Parkinson's, and so in that case we're sort of treating the root cause. So if people are having stiffness or pain, motor symptoms overnight, then we need to be changing the levodopa. If it's anxiety that's keeping people awake, you can't turn your brain off, then certainly that needs to be treated differently than instead of with levodopa. The bladder can be a big contribution to lack of sleep overnight. So sometimes lifestyle modifications in terms of the amount of fluid in that, especially late at night, can be helpful. Some of us in the audience have a prostate, which can impact how active the bladder is overnight. So sometimes that requires treatment. And then there are some prescription medications as well, which can help with bladder frequency and urgency. Non-motor symptoms, again, constipation is very, very common. I often direct people to one of the resources on the Parkinson's BC website. So if you search Parkinson's BC and constipation, there's a very good approach to dietary changes in that before making any medication changes to help with constipation. Increasing fluids and exercise can also be helpful for this. And then one thing I also commonly use if those above changes are not helpful, something called polyethylene glycol, or PEG, which works by pulling fluid into the gut. So still fluid, quite important in managing constipation. And again, other than just being a bit more comfortable, as we said, constipation is very important to treat because it helps make the levodopa more effective, get absorbed more easily. I think this was actually discussed by Dr. Squires yesterday. So I will sort of leave that, and just if there's any questions, I can answer those. But otherwise, that's the majority of the talk. And so I would be very happy to take questions from the audience.
So we have some questions, Dr. Mackenzie, in the chat box. Would you like me to read them, or would you like to read them out loud and then answer?
Yeah, I'm just, I pulled them up here. So we have a question from Mike saying that his neurologist told him to take the levodopa an hour prior to food or 2 hours after food. I would say that's certainly good advice. I do find if we're first starting medication, I usually don't give people strict sort of mealtime guidelines unless they come back and tell me that they're not feeling the medication do much. In that case, we might try moving the medication away from food. And my recommendation is generally, an hour on either side of food. So an hour before or an hour after. I think sort of when we're first starting medication, sometimes separating from meals is more work than I think needs to be done, because most people don't feel any different whether they take it with a meal or not. And certainly I know I have a lot of patients that find it much easier to remember to take medication if they match it with meals. So if you're trying to avoid meals, sometimes setting alarms or that for medication might be helpful. So that's sort of advice on that. Although certainly you can follow up with your neurologist about that. But I'm not always so strict if people are responding well to medication, I think is the take-home point there. Yeah, so then we have another question asking about the clinical trial in Sunnybrook in Toronto using focused ultrasound, or known as FUS. And then other trials or other technologies being used in Israel that uses ultrasound to target brain tissue affected by Parkinson's. It is, I think, an interesting thing that's coming up. So there is a lot of good evidence for managing essential tremor, which is a tremor disorder, which obviously is not Parkinson's, but very good evidence in managing essential tremor with FUS. Essential tremor can also be treated with DBS, like Parkinson's. And so I think there is some interest there in terms of the trials. I think one of the concerns is that it's mainly to manage the tremor symptom of Parkinson's. And so similar to if we focus the DBS, deep brain stimulation, on tremor, the FUS, or focused ultrasound, targeting an area of tremor might be very effective for tremor, but generally isn't managing other symptoms of Parkinson's. Sort of, when we think about smoothing out motor fluctuations, it's not doing that. And so I think in the right person, this might be a good option in the future. We're certainly quite limited right now in terms of traveling to do something like this to another province or another country, but and even for essential tremor, that's the case. So I think it potentially has some promise in the right person, but I think we have to be cautious because it's treating tremor but not motor fluctuations, not other manifestations of Parkinson's. As far as I'm aware, wouldn't be doing something like FUS and DBS on the same patient. So it's kind of one or the other. And you're kind of picking tremor over other motor complications. So a question from David: what can help with freezing? That's a very good question. So my first question back, usually to someone who's having freezing, is whether it's happening when they're off, so feeling stiff and slow, and maybe their tremor's worse, or whether it's happening at random. So if freezing is happening with sort of off periods in between, then often your neurologist can help you alter your medication doses and timing to help minimize those off periods. If freezing is happening at random, so even if you're feeling good, then generally sort of changing the levodopa medication timing is not going to be helpful. So what we often do with that, there are some other medications that have limited impacts that are more rarely used to help with gait. So that would be something to discuss with your neurologist. But I would say that on-time freezing is a much trickier thing to treat. And often we're trying to help sort of minimize environmental stimuli and that kind of thing to help with those symptoms. We have a question from Carol about the maximum daily dose of levodopa. And really there's not a sort of finite cut and dried number. So I think, we want people on the medication dose that they need, right? So if you're reviewing things with your physician, and if your loved one or yourself were having increased symptoms that required the increased dose of levodopa, then that's certainly appropriate. We also have many other medications, a few of them that I went through, that sort of impact how much levodopa is really there. And so there's not a cut and dried maximum. It's more that we're increasing it in a thoughtful way as needed. So we do have a question from Mike about CBD oil. I wasn't sure if everyone would have attended yesterday and heard about that, so I can certainly talk to that. So my CBD oil does not have much in the way of evidence in terms of helping with Parkinson's symptoms. So it's not like, unlike the levodopa or that, it's not like I can point to a study and say, aha, I expect it to help with this and I expect it to help in this way. So there is a lack of evidence, although I think as CBD is becoming more common, we will probably have more studies for a lot of different things that CBD might be helpful in treating. My biggest concern right now is similar to that of the mucuna. So if you get levodopa off the shelf, it says it's 100 milligrams, and you know that it's 100 milligrams because it's been tested and it's regulated by Health Canada that it has to contain that much. If you go by CBD, you're being told that it's a certain amount of CBD to THC ratio, but that's not actually guaranteed. So because it's not regulated like a medication, we don't actually know that for sure. There's been many, many studies on different supplements that you buy from the drugstore that contain a variety of doses other than what you think you're really receiving. So you could be buying something that you think is mostly CBD and actually getting something with more THC, a more psychoactive medication than you intended. The other thing is each tablet of something like levodopa has to contain that amount. And if you cut the tablet, we know that actually each half is that amount. If you're taking something like a CBD oil, you're sort of taking it on faith of what's actually in the bottle, and there's no guarantee either, because again, it hasn't been regulated or tested that you're getting the same dose. So if you're taking a drop or a gummy, you don't actually know that that you're getting the same amount each time. So I think that's a big cause for concern, particularly in Parkinson's, because we often rely on routines in Parkinson's. So, you know, if things are getting a bit more complicated, meds at the same time, eating at the same time, that kind of thing, and minimizing big changes, big swings day to day. And something like CBD oil might be adding in those swings, and you might not even know it. I do also, you know, usually not in early Parkinson's, but more advanced, I do have concerns with some of the potential side effects for CBD. So this obviously doesn't apply to anyone, but it can worsen things like cognition. So if someone's having trouble with their thinking or memory, or even hallucinations, then certainly this may worsen that. It can worsen kind of energy, you know, fatigue and apathy levels, which can be a problem in Parkinson's. And so I think it's something that I'd like to see more evidence about, and I would like to see regulated more like a medication before I would be comfortable sort of endorsing it to my patients. An excellent question asking about Parkinson's and the COVID vaccine. And so I can very happily say that there are no issues with Parkinson's and getting the COVID vaccine. So there's no specific interactions in the brain with the Parkinson's itself or with the medications or that. Certainly, you know, there can be some brief symptoms after the vaccination, particularly the second dose with a lot of the ones that are out now in terms of, you know, fatigue or a low-grade fever, that kind of thing. And we do know that if people are experiencing this symptoms, your Parkinson's is going to artificially feel a little bit worse when you're sick, but certainly that's going to be very mild time compared to actually getting COVID. So I would wholeheartedly recommend getting vaccinated with the COVID vaccine. Parkinson's itself doesn't put people at increased risk of getting COVID or getting severe COVID, but certainly for a lot of people, age into this in terms of risk for a vaccine. I am eagerly awaiting getting my own COVID vaccine. So a question from Sharon Jeet asking about high protein foods that should not be eaten with medication. Again, I'd reiterate that this is only a problem for about 1% of people and many years into Parkinson's. This is something you could meet with a dietitian and talk about, but usually high protein foods are things like the protein that we take. So, you know, chicken, meat, fish, and then dairy products have some amount of protein. But certainly something you can talk about further with a dietitian, for example. And then a question from Joan on Alexander technique as a therapy for Parkinson's disease. So this is something I've had a few patients use and have success with. I'm actually not sure, I'm not familiar if there's been much in the way of evidence or literature to help support that. So again, I think like exercise, well, there's good evidence for exercise, so I'd put that in a separate category. But, you know, if we're talking specific therapies, alternative therapies, specific exercise, boxing versus dancing versus if it's something that you are interested in trying and it's reasonable to access in terms of the price and that, certainly that's reasonable to do, but it really is kind of exercise, that 30 minutes of getting your heart rate up sort of as often as you can, or at least several days a week, that's been proven in the literature to help change or slow progression of Parkinson's. So a question from David about lithium being used to treat Parkinson's disease. No, not as a treatment. So lithium tends to be used more as a mood stabilizer medication. If people are having sort of rapid cycling mood in something like bipolar, then that tends to be used as a mood stabilizer, but not something that would primarily be used to treat Parkinson's disease. There's not any evidence that, whereas all the other medications that we have approved to treat Parkinson's have a robust amount of literature behind them proving that people do better on these medications. And then another question talking about overactive bladder and specific medications. There are a wide variety of medications used to treat overactive bladder. And so certainly I think the one I mentioned on the slide is not the only one. So I think reviewing with your physician about the medication that they've recommended and the side effects of that. There are some medications for overactive bladder that can have some side effects of cognitive as a side effect. So I tend to sort of strictly avoid those ones in Parkinson's. But certainly if you have any concerns about the specific medication you've been put on, you can review that with your physician. So a question about touching on marijuana doses to help with sleep. And I think that's again, I don't have literature to point to say, aha, you should take this milligrams to help you go to sleep. And even if we did have a dose to recommend, I couldn't guarantee that you're getting that dose in however you're taking the marijuana. So it has to be something I'm not recommending because I can't do it in a safe and evidence-based way, the way I can recommend other medications or other strategies to help with sleep. So question from Ben about overactive bladder. Has been helping, and he said with does not interfere with Cinet. So that's medicine that very, very few interactions with other drugs. So we tend not to have to be very careful. You could take those medications together if that medication dosing is easier. Kind of the one thing that I often come across beyond that they need to avoid with levodopa, taking it at the same time, is iron, because that or a multivitamin with iron in it. This is the absorption of levodopa. So that medication we should be splitting from the time that you're taking the levodopa. But otherwise, the vast majority of other medications, including the tamsulosin, which is helpful for prostate, which often contributes to bladder symptoms, can be taken with levodopa, and there's no interaction. Question from one of our guests about the PONS device, so PONS, for treating Parkinson's. So it's still BC, and this would be another thing that, another strategy or device that does not have good evidence behind it. So to get a device like the PONS approved, to get a medication approved, you have to prove in research that it's effective and that it's safe. So you need both of those before a medication gets approval. For device ones, you only need to prove that it's safe. So you don't actually need to prove that it's effective for treatment. And there's not any high quality research to say that that is effective in treating Parkinson's. I think a good strategy, and if you're reviewing a treatment or other or devices, the longer the list of things it's supposed to treat, the less likely it is to actually have much benefit for anything other than placebo. So, you know, the newest, greatest thing, it treats Parkinson's, it treats MS, it treats Alzheimer's, you know, it treats 10 different things. That would kind of put my spidey senses up that it's a kind of a red flag that there's not much evidence behind that treatment, and that's not something that's available here at this point. Is acupuncture beneficial for Parkinson's? From one of our guests. So not specifically. So some people do find benefit in terms of sort of muscle relaxation or the increased blood flow that they have with the acupuncture. Kind of symptomatically, it's not going to have impact on Parkinson's directly. You can also think things like acupuncture and massage, they're targeting things at the muscle level, which, you know, seems reasonable because there's muscle stiffness or rigidity that comes with Parkinson's. But actually that stiffness and rigidity is driven by the brain. So if people symptomatically feel better with those treatments, there's not danger to doing them, to using them, but I don't expect it to be making much difference because they're not having an impact on the brain, which is actually where that muscle stiffness is coming from, even though it obviously you're feeling it in the muscles. Research for a cure. So there is a great deal of research going on right now, looking for different strategies to stop Parkinson's or to sort of slow progression or that kind of thing. So a variety of different companies, a variety of different strategies. It is a very active area of research, and I think there's a lot of funding being put into it. You can imagine with our aging populations in a lot of the world that Parkinson's is sort of becoming more common because people are living longer. And so it's a very active area of research. I would not say there's anything, you know, that I think is going to be immediately available in terms of a treatment that I could offer to people outside of a study. At UBC and at other centres, we are, you know, participating in different trials. There isn't something right now that we are recruiting for, and that's because there isn't something right now that is sort of been proved to be safe and effective in early trials. So I think it's certainly a question of watch this space for future developments, but there's nothing that I expect to be kind of immediately available. So thalamotomy, so for tremor, yeah. So tremor in the thalamus, so targeting that with DBS is done. But in terms of thalamotomy itself, I'm not aware that it's available or something that's being done. Generally, the thalamus is being targeted with things like DBS or the focused ultrasound, which we've spoken of. So question from Ben about mirtazapine. So he's on it and he thinks it helps his sleep. And it's a medication for mood, and he's a little bit worried about dependency on it. So I think it's a good question. Mirtazapine isn't a sleeping pill, so it's not. There's a lot of sleeping pills that we worry about developing a tolerance to or developing a dependency on. And so mirtazapine is not in that category. Actually, the fact that it helps with sleep is a side effect that we're using to our benefit often in Parkinson's. So it's a medication for mood and anxiety. And because it has the side effect of making people a little bit sleepy, we can often use it at night and help improve people's sleep. So I tend to use it in people who have trouble with mood or anxiety and also sleep, because I can hit kind of 2 or 3 birds with one stone. I wouldn't suggest you're weaning off medication until you've spoken with your physician who prescribed it. I do often find, if you think of the changes in the brain with Parkinson's, so we know that the dopamine levels are down. We're supplementing those with the levodopa, but downstream from the dopamine chemicals are the mood chemicals. And by replacing with the levodopa, we're not actually directly impacting those. And so I do have a lot of people that need to be on a low dose of medication to help modulate the neurochemicals involved in mood and anxiety. So I do have a lot of people that are on long-term medication, specifically mirtazapine dependence or tolerance to it, where you need higher and higher doses, is not a concern. Certainly if you're having side effects or worried about the number of medications you're on, I'd suggest reviewing with your physician who prescribed it, whether that's your family doctor or your neurologist. But I will say it's very common in Parkinson's to have people on a medication longer term for mood or anxiety, and that's because there's sort of limited other ways to modulate those chemicals, which are also changed in Parkinson's. A question from one of our guests about when starting medication, should all symptoms disappear? And if so, for how long will symptoms be controlled? So good question. When my goal when starting someone on medication for Parkinson's, the goal is not to not know that you have Parkinson's, right? If we push the dose high enough, certainly all the symptoms might disappear and you might not know you had any symptoms. I think it depends at which point we're starting medication. So if I'm starting medication in someone quite early in Parkinson's, sometimes they do feel like all their symptoms have gone away, even on sort of the 1 tablet 3 times a day, which is our starting dose. For other people, they feel better. So they feel like they can do the things they want to do. They can get through kind of their exercise, and their dexterity is good for other tasks. They certainly don't have 0 symptoms of Parkinson's disease. And so the goal isn't 0 symptoms, but the goal is managing symptoms. In terms of how long the medication will control symptoms, sort of as we talked about, over time, because the brain is producing less dopamine, expect someone to be over it. So if the brain is producing less dopamine, then we're needing to supplement more as the years go by, because you're kind of more dependent on what you're taking in for supplementing with that medication, because the brain is producing less. So as we said, the medication never stops, but everyone's a little bit different in terms of how things change over the years. Most people at some time down the road, we often are increasing medication from the starting doses of medication. Question from Fariwa, are there steps to take to prevent the development of levodopa-induced dyskinesias in patients who are diagnosed at a younger age and are taking levodopa and carbidopa? It's a very good question. So the short answer is sort of. So we know this is one of the reasons that I don't just pound people full of medication until their symptoms 100% disappear. We know that higher individual doses of medication are a little bit likely to cause dyskinesias. But if we think back to kind of that therapeutic window, most people who have a diagnosis at a younger age may develop some dyskinesias at some point, okay? So this isn't universal, this isn't everyone. But even if you didn't take medication for the next 20 years with Parkinson's, if you started medication, you would still have dyskinesias. I know because they did a study on this. So they compared a cohort in Europe who'd had a medication for Parkinson's and a medication naive, meaning they'd never had exposure to medication. As soon as they started those patients on medication, they develop dyskinesia. So that's telling us that it's not the exposure to the drug over 20 years with Parkinson's, it's the fact that the brain is changing in the background. So there's nothing to do 100% to 100% prevent it from never happening. I will say again that it's change in the brain over time that's causing this, and that although it might seem hard to believe, the vast majority of people I have with some dyskinesias, I ask them about them, and they tell me they don't even notice it because they're so mild. And I ask them, do you feel better right now, or do you feel better when you're sort of waiting for your next dose of medication when it wears off? And almost universally, they tell me they feel better right now in front of me when they're having a dyskinesia. So I know it is a scary thing to think about, and I think part of the problem is that any movement disorder, anything in medicine, if you look it up on the internet, you only get really severe, extreme examples. The majority of people, dyskinesias are quite mild. They've done reviews, symptoms are quite mild. People are not bothered by them. And even in the majority of people, they're not even needing to change medications to help with dyskinesias. So it is something that I'm cautious of. I don't give people more medication than I think they need to be sort of effective in their day-to-day life and exercise. But I also know that because the brain changes over the years, there's not a way to 100% prevent dyskinesias. So question from Joan, besides aerobic exercise, do other types of exercise such as yoga, Tai Chi, strengthening help slow progression of Parkinson's? Well, so our best evidence for actually slowing as in the aerobic. So that's kind of getting the heart rate up for at least 30 minutes at a time. This will the main topic of next week's discussion, so I think we can defer that a little bit there. In general, a lot of other exercises, I have many people I follow who feel better doing those, so adding those into their routine, but there isn't the robust evidence that we see with aerobic exercise in terms of slowing progression. That's certainly not to say that those things aren't helpful. I often recommend people try different strategies, different routines, and find what works for them. The aerobic exercise, though, is something I'm recommending to everyone because we have such good evidence that it slows progression.
Melissa, thank you so much. We are just approaching, it's 12:01, so perhaps we can...
Oh, I didn't even notice.
Perhaps we could defer the last two questions for the final question and answer period, or did you want to quickly answer them or save them?
Yeah, I will stop being so wordy and will quickly try to answer the ones that are here. Myself and Dr. Squires are joining for a Q&A session next week at the end of our session on exercise, but in case people can't join that as well. So a question, does L-Dopa have adverse interaction with vitamin supplements? No, other than the iron, as I'd mentioned together, and that's an absorption problem. So you can take the iron, just not at the same time. Question from Ben, any idea when the brain cells that produce dopamine stop working or die out? So the brain cells are producing less dopamine more than a decade before people have any motor symptoms of Parkinson's. That's why things like the REM sleep behavior disorder acting out the dreams can predate Parkinson's by a decade or more. The brain never completely stops producing. It's just sort of less and less over time. Progression is very individual, so it's difficult to predict. People's past best predict future. So someone's 5 years in, so I've been changing very slowly. I expect things to continue to change slowly. And the question, our brains naturally slow down the production of dopamine because we are supplementing it with levodopa? No, so that's what I touched on, in that they have done studies comparing different groups and have proven that the levodopa is not toxic. So it's not speeding up the progression of Parkinson's by taking it. Thank you very much for the kind comment from Shafiq and Carol and Mike and other people. Thank you very much.
Thank you so much for putting on such an informative... Pardon me? I was just saying that's it for questions. Oh, okay. Yes, thank you so much for putting on such an informative presentation for us and answering all of our questions. And thank you everyone for participating in our workshop today and for all of your great questions. So as Dr. Mackenzie mentioned, our last talk in the series will be on exercise with neurophysiotherapist Michelle McCarthy, and that's on the 24th of February. So it will be at 11 o'clock as well to 11:45. And then following that, we will have a 30-minute question and answer period session with all of our presenters reconvening for us to answer all of your questions. So please don't miss that. Thank you all and have a great afternoon.